Hi everyone, my name is Anne-Marie Harkins and this is a critique of muscle dysmorphia. So we'll start off with the presentation in defining muscle dysmorphia, then we'll discuss the social factors and stigma associated with the disorder. We'll discuss the prevalence and steroid abuse. Then I'll examine several studies that compare the cognitive, behavioral, and emotional symptoms between anorexia nervosa and muscle dysmorphia. We'll propose possible causes and treatment, and finally, I will criticize the placement and categorization of muscle dysmorphia in the DSM-5. So what is muscle dysmorphia? MD is actually a specifier in body dysmorphic disorder under anxiety disorders in the DSM-5. It's defined by the preoccupation of the idea that the individual's body build is too small or inadequately muscular despite their true observable appearance. The disorder causes significant distress and repetitive behaviors are often displayed in efforts to alleviate symptoms. Alavardia suggests additional behaviors to categorize MD, such as situational avoidance to deny body exposure and the continuation of excessive dieting and exercise. Pope proposes the term reverse anorexia as the sole differentiating factor is of body size. And with the combination of increased popular trends such as competitive bodybuilding, extreme sports, and the lack of research on male eating disorders, it creates a stigma. The majority of research on eating disorders has focused primarily on women, with less than 1% of male representation. Therefore, eating disorders are seen as uncommon in males and that the behaviors are primarily thinness-oriented, pushing the stigma even further that eating disorders are feminine and viewed as weak. Not to mention that today muscularity is praised and the behaviors associated are glorified. Bodybuilders are the epitome of health, fitness, and sex appeal. And due to this stigma and lack of insight, it is difficult to estimate the prevalence of muscle dysmorphia among bodybuilders and the general population. 2010, 13.6% of bodybuilders tested for MD diagnosis, and then in 2017, that number jumped to 25%. 4 to 12% of bodybuilders reported using steroids. 42% of bodybuilders with MD are reported to using them as well. The medical risks associated with steroid abuse should be alarming enough. However, there are psychological effects as well, such as increased irritability, aggressiveness, grandiosity, and recklessness. In efforts to compare these symptoms across muscle dysmorphia and anorexia, we're going to review several studies. In one study, they compare the psychological symptoms and traits in anorexic females and male bodybuilders. They tested perception, personality traits, and behavior. Both groups showed tendencies of obsession, perfectionism, anhedonia, and pathological narcissism over the general population. Another study tested pathological behavior and cognition between bodybuilders with muscle dysmorphia and those without. The results suggest individuals with MD thought more often about their muscularity, displayed dissatisfaction with their overall appearance, checked their appearance more often, and felt more dependent on weightlifting than controls. Additionally, the study found higher rates of comorbidity in mood and anxiety disorders. Those with MD showed 65% showed comorbidity with mood disorders compared to the 29% of controls, and all of which of these mood disorders were major depressive. In Chandler and colleagues' study, they found significant relationship between MD symptoms, anxiety, and obsessive-compulsive symptoms. When proposing possible causes, researchers suggest a combination of fragile self-esteem and narcissistic perfectionistic qualities increasing the likelihood of engaging in appearance-enhancing behaviors. This This becomes excessive when combined with obsessive-compulsive symptoms. Of course, socio-environmental factors might have a part to play as body image represented in the media shifts. One study suggested childhood bullying victimization as an influential factor. Oftentimes, children of lesser body size or are perceived as weak become targets of bullying. In this study, they found those who displayed prior low levels of self-esteem, body dissatisfaction, and became victims of bullying were at higher risk of MD diagnosis. Many people with muscle dysmorphia might not seek treatment. The behavior that they engage in is seen as physically healthy, such as excessive dieting and overuse of supplements, excessive weightlifting. However, these are mechanisms of coping with psychological stresses associated with the disorder. While these behaviors might not alleviate all of their anxiety, some individuals with the disorder display little insight in them. Only about 60% showed fair insight in their symptoms. Those who do seek help might be turned away due to the stigma. So throughout this research, we see little difference between the features of muscle dysmorphia and anorexia, both showing significantly more obsessional, perfectionism, pathological narcissism over the general population. Discovering the vast similarities in cognitive, behavioral, and emotional symptoms among the two disorders, the categorization of muscle dysmorphia is questionable, and it brings criticism to the placement in the DSM-5. Appropriate placement is essential to the most effective treatment and to the patient's overall well-being. So future research is highly suggested. Okay, and these are my references. Feel free to look those over, and thank you for your time.